Good morning. It is 10 o'clock, so I will go ahead and get started with our, I don't know, they were monthly, then they were not, and then we had some scheduling difficulties. So I'll just say our November webinar, put it that way. We're hoping to get back on track after the beginning of the year with a little bit more regular meeting on these. We are fortunate this November to have one of our great resources in the tobacco prevention and control program. I'd like to welcome Brody Maack from the North Dakota University, or excuse me, NDSU School of Pharmacy, and also a TFND board member. I don't know if Heather had any additional words as a co-sponsor of this event, or if I could just turn it over to Brody.
Abby, thanks for the opportunity, but go ahead and turn Brody loose. Thanks for having us.
Super. Very good. Thank you, Brody.
All right. Thanks, Abby. Thanks, Heather. Nice to see everybody's names on the screen. I'm going to be talking today about partnering with pharmacists for tobacco and nicotine treatment. And some of you may have heard some of the information that I'm going to go through, but I think, probably a good number of you have not. And so for some, it might be a little bit of review, but I'm also going to share some information on some things that have been changing here over the past few months. So I'm excited to talk about that today. And I'm also excited to hear from you guys and make this a little bit interactive throughout. And so feel free to chime in with questions. I'll also try to get done a little bit early here, so at the end we can have a little bit of discussion and Q&A too, if need be. So as Abby said, for those that don't know me, I'm faculty here at the NDSU School of Pharmacy. I'm also a clinical pharmacist at Family Healthcare Clinic here in Fargo, which is a community health center. And that's where I do most of my clinical tobacco work. I'm also a grantee with the Tobacco Control Center with the ND Quits Grant program. And also I'll talk a little bit about a program with the Tobacco Control Center that I'm doing a little bit of research in, trying to get pharmacists doing more of this work. And so that's really what led to this presentation today. So nothing to disclose. I do have some learning objectives, but I think I'll just dive right in. We'll talk a little bit about pharmacists, what we can do, some opportunities that already exist, but really, what are the scenarios where we can partner more with all of you as pharmacists? So why even consider pharmacists, I guess, is the first question. What makes pharmacists somebody that we would want to be collaborating with in the tobacco treatment area? And as most of you already are aware, that there's almost 500,000 people that die every year in the U.S. from tobacco-related disease. That number is actually higher than that. That's just the most recent published number that I've seen. And then you can see the data on the screen, which again, I think many of you are probably aware. Actually, there's more recent data that just came out. I haven't had a chance to update my slide here, but really, in North Dakota, I think the middle column here is really what concerns me the most. Obviously, we are higher than the national average across the board in everything: adult smoking, youth smoking, adult and youth smokeless tobacco, and ENDS use. And so obviously we have work to do. We've come a long way, but we have a lot of work to do. And so trying to find opportunities where um, we can add opportunity for patients to be identified as tobacco users, as well as treat those tobacco users, is important for us to consider. The other thing is, if you think about pharmacists, we are accessible, especially in rural areas. And so you think about a state like North Dakota, um, we are a largely medically underserved state. And a big part of that is because it's a rural state. And so you get out in some of the western areas of the state, northern, southern areas of the state, and you get outside of Fargo and Bismarck, and there's really sometimes the pharmacy is the only healthcare provider within 100 to 200 miles for people. And so that's the clinician that those people will be able to access. Also, we have a unique ownership law in the pharmacy world here in the state. And for those that aren't familiar, the law says in North Dakota that every pharmacy has to be 51% owned. In other words, every pharmacy has to be majority owned by a pharmacist or group of pharmacists. And that's why we don't see some of our corporate retail pharmacy companies in North Dakota, such as CVS, Walgreens, Rite Aid, and those types of companies, because they're not pharmacist owned. In other words, what that means is every pharmacy in North Dakota is essentially independently owned. And that comes with some challenges, but I think it comes with a lot more unique opportunities. And so thinking about implementing new services, partnering with new, community partners and public health agencies, these folks that are running these pharmacies can kind of do whatever they want. There's no corporate level chain of command that they have to go through to make decisions. And I think that's a unique opportunity for pharmacists to partner. And we are the only state in the country that has that law. So I think it's something that we that we are proud of, and something that that you won't see anywhere else. Um, there are pharmacists that actively lead tobacco treatment services in a variety of settings, both in community pharmacy as well as what we call ambulatory care, which is kind of like pharmacists in a clinic setting, but not dispensing. So practicing more as a clinician. But again, I'll talk in a little bit how that's not commonplace in North Dakota. And then we'll talk a little bit here about the scope of practice. So what can a pharmacist actually do? Many of us probably envision the pharmacy that we may have gone to or maybe frequent, and you see the pharmacist behind the counter putting, pills from a big bottle into a little bottle, and that's kind of the common, misperception of what pharmacists do. But in fact, what our law says that we can do is very broad. We are r- highly recognized as medical providers in the state of North Dakota. So you can see some of the things in our law that I've highlighted. You know, one thing that we do is drug selection and dispensing, but we also monitor drug therapy. We administer drugs. We are recognized as a primary healthcare provider of what we call pharmaceutical care, or essentially optimizing medications. And we also have the ability to prescribe, and we'll talk a little bit about what that means in the tobacco world. We can enter into agreements with physicians and nurse practitioners to be able to actually prescribe medications and adjust doses, order lab work. So it goes well beyond just the dispensing role. We're involved a lot more in optimizing medication therapy. And so when it comes to tobacco treatment, that's important because actually just last year, North Dakota legislature approved a law that allows us to prescribe tobacco cessation medications without needing to enter into that agreement with physicians and nurse practitioners. Essentially, it recognizes us as independent prescribers of any of the 7 FDA approved options. So nicotine replacement therapy, varenicline, and bupropion are all fair game for pharmacists to prescribe. And that literally means that a pharmacist in your pharmacy have to go through a couple hoops, which I'll talk about. But once they meet the standards, then they are able to prescribe those without needing to involve additional barriers, such as trying to get a physician to prescribe it and things like that. So that kind of opens up the door for patients that may only have access to a pharmacy to be able to get that care much more easily. So the requirements for us to be able to prescribe tobacco cessation medications are, I think, pretty reasonable. We have to be actively licensed. We have to, do kind of a refresher training and education module. Not real extensive, but it's something that's been approved by the Board of Pharmacy. And you can see the link I have there on the screen. That that it's geared toward pharmacists, and it's meant to satisfy the law, but it's actually a good module for anybody to take to kind of get a good refresher on the medications used to treat tobacco and nicotine use. And then obviously we have to be acting in good faith, using reasonable care, keeping up to date. That's just something we do anyways. And then there is a statewide protocol that's kind of delineates what we can and can't do. There are some limitations where we should not be prescribing, and we really have to be involving a patient's primary care provider. I'll talk a little bit about that more here in a little bit as well. So again, we are able to prescribe, after we meet those requirements, all of the tobacco cessation medications approved by the FDA. And this law allows us to have, to use our clinical judgment. If we want to use combinations of these products, we can do that. If we want to use doses outside of the FDA approval range, which is commonly done in tobacco treatment, we can do that too, as long as we're acting in good faith, using best practices and current clinical guidance, we're able to do that. So some other just elements here on the next couple slides about the protocol. So again, the protocol sort of drives what we can and can't do as prescribers of tobacco treatment. And so, just to highlight a few things, it does sort of require us to get patient consent. That doesn't mean that we have to have each patient fill out some consent form. It's just kind of a standard of practice, making sure that the patient agrees to receive care from a pharmacist. And we also have to identify high risk patients. So you can see, patients who are pregnant or plan to become pregnant in the next 3 months, or if they have a contraindication to any all of the medications that we'd be using for one reason or another, those would be considered high risk patients. And those are the patients that we need to involve primary care providers in order to be prescribing. We can't just go ahead and prescribe medications for those patients. So that's kind of one important piece of that puzzle. But it does, advise us that we should be providing behavioral counseling. So it's not just us prescribing medications. It's also becoming sort of tobacco treatment clinicians, and most of you on this webinar have all gone through that training and are doing this on a day-to-day basis. And so that's something we're trying to get more and more pharmacists to do, is become trained as, whether it's a TTS provider or some other type of training. We want to make sure that our pharmacists are comfortable counseling patients on the behavioral aspect of tobacco cessation. Obviously, we've also incorporated that here at NDSU in our pharmacy program, making sure that our students graduate prepared to counsel patients on tobacco cessation, and also prepared to prescribe those medications right out of the gates. There's also a requirement that we follow up with patients. So when a patient comes to a pharmacist and we're prescribing medications or we are counseling them to quit, it's not just a one and done thing. This protocol sort of advises us that we should be following up with patients. So that's a standard of care that we're kind of operating out of. And it's not just that we're on an island. We're not, taking over the care and ignoring the patient's primary care provider. We are required to communicate with the PCP exactly what we are doing as soon as we can. And so that's, again, just kind of a best practice. We want to make sure that if we're starting a new medicine or treating a patient to help them quit, we want to make sure that the PCP is in the loop and they're aware of that. And there are times where we're not just going to do it. We're going to run some things by that PCP. I think about bupropion specifically. I usually like to make sure I get the PCP involved right out of the gates if I'm going to be prescribing bupropion, because it can be used for other things besides just tobacco cessation. It can be used for weight loss. It can be used for depression, anxiety. And so I don't want to, worsen a condition by starting that medication. And I want to make sure I have all the information, as well as the, primary care provider's consent and agreement on that. And then, of course, just like any other primary care provider, every time we provide that care, we document our visit so that we can follow up. And as well as, if the patient comes in and wants to see that documentation, they have every right to do so. So really operating in that sense as a medical provider with regard to tobacco treatment. And just to go one step beyond that, in the pharmacy world, when this all started, we were obviously really excited about that. But as we all know, it's difficult to start doing something like that unless we're able to sustain it and support it financially. So then the next question is, well, if we're going to be doing the tobacco cessation counseling and things, will insurance companies recognize us as medical providers for that service, and will they reimburse us for that? And so it was nice to see, around the same time that this law was passed, that North Dakota Medicaid came out and did clarify that, yes, pharmacists are specifically recognized as healthcare providers, and therefore we're able to bill for those tobacco cessation counseling services. And again, just to recap, I won't go through this whole slide, but Medicaid coverage, now provides coverage for all members. It's not just pregnant women, which is what it used to be. Medicaid expanded that tobacco cessation counseling coverage, and you can see there's two CPT codes, or billing codes, at the bottom of this slide. One for if the encounter is between 3 and 10 minutes, and the other if it's greater than 10 minutes. Those are the codes that pharmacists can submit, and also many of you as clinicians can submit and be reimbursed by Medicaid for these tobacco cessation services. So just to recap, it's kind of the perfect storm, although it's not a storm, it's more of an opportunity that, we are now considered independent prescribers of tobacco treatment medications. We are recognized as providers in the sense of tobacco cessation and treatment in North Dakota, and we have a billable opportunity. And I should preface this too, but to say that there are other payers in the state beyond just North Dakota Medicaid that are also reimbursing pharmacists for tobacco treatment. And so it's nice to see that most of our commercial carriers have also followed Medicaid's suit in reimbursing pharmacists for tobacco cessation counseling as well. All right, so I'll pause for just a second. Any questions on that before we talk a little bit about kind of how to partner with pharmacists?
Brody, this is Brady and Mandan. I have a question regarding the prescribing stuff. Those last couple slides you gave are great. Do you provide any education to any statewide pharmacy groups so they are aware of all of this stuff? I mean, we can get information out to them fairly easily, but I think if they hear it from somebody of your stature and where you're coming from, they would take that to heart a little bit more.
Yeah, great question, Brady. Actually, when this all first started, I kind of helped develop the protocol for prescribing and collaborated with our board of pharmacy. And so the nice thing about the pharmacy world in North Dakota, we're kind of like a small town. There's only about 1,200 of us total in the state. And so it's really easy to get information out to everybody. And so the board did a really nice job, along with the North Dakota Pharmacists Association, of informing everybody about the law, informing all the pharmacists about the steps needed to take in order to be a prescriber of tobacco cessation meds. So that was done. And then as an ongoing effort, we have an annual meeting every year in April. And I think for the past 3 years, and I'll be presenting again upcoming in April, but every year we tend to touch on this so that everybody who attends that meeting is kind of kept up to speed on how things are going. And if you're not doing it, here's how you do it. And so does that kind of answer your question, Brady?
Yes, it does. Thank you.
Perfect. Any other questions so far? All right. So let's talk about opportunities to partner with pharmacists and how that looks. Um, and when I say pharmacists, obviously I'm focusing a little bit on pharmacists practicing in a community pharmacy. But as many of you might know, there's pharmacists obviously in the hospital setting, there's pharmacists in clinics, there's pharmacists that don't really practice in a clinical area, lots of different settings that pharmacists practice. And so we hope to get there where, talking specifically about our pharmacists in the hospital, I hope we can start getting this embedded into hospital practices, and pharmacists that are doing rounds with medical teams and patients on discharge, admission in the ER setting, you name it. And so that's a place we hope to go. But right now we're kind of starting with focusing in on the community setting, just recognizing that they have access to their communities so easily. So the future, the hope is that we can get pharmacists to implement the ask, advise, refer process, where every patient that comes into the pharmacy is asked about tobacco use. We're all preached in clinics and hospital settings that, that's what the guidelines say. Ask every patient at every encounter. And so the hope is that we can implement that in the pharmacy world as well, because that's not commonplace. There are some pharmacies doing that, but most don't. It's not a common question that you get asked when you walk into a pharmacy. And then everybody that is a tobacco user, obviously, hoping that pharmacists advise them to quit and then refer them at a minimum to ND Quits or other local programs, such as what you guys are doing. And then obviously, providing in-house cessation services. I just talked about all those opportunities and pieces in place for pharmacists to be able to counsel, prescribe, treat patients for tobacco treatment. And so the hope is that we start to see more and more pharmacists in the community setting do that. And so when this all started to come out last year, we got a group together here at NDSU, kind of on the research side, to look at, how many pharmacists are actually already doing this as that law kind of was passed. And so you can see in this slide here, we surveyed pharmacists in the state about everything that they do beyond just dispensing. And there's a big laundry list here But you can see only 21 out of the 235 respondents of that survey were actually doing anything with regard to tobacco cessation. And so that's only about 8.9 or 8-9% of pharmacists that responded, which the response rate of 235 was pretty good considering we only have just over 1,000 pharmacists. So we felt like we had a pretty good picture of the fact that, when all these pieces were coming into place, there's not many of us actually doing anything with tobacco cessation. And I can tell you one of those 21 was me. And I know several others, through IHS and some of the other partners that talked to in the pharmacy world that are doing this work. And so we hope to really start to expand this, but it kind of gave us an opportunity to really dig into this a little bit more. The other thing we look at is, of those 21 that were providing tobacco cessation, how many were actually billing for it at that time? And we saw that only 4 of them. So that 19% on this slide is actually 19% of the 21. So that's a even smaller percentage of the overall respondent list that took that survey. And of course, I'm one of those 4. So 3 other pharmacists besides me reported billing for tobacco cessation. And so, looking at this, we thought, well, we're starting from scratch. We need to really start from ground zero. And how do we get pharmacists to start doing this work? And then we need to teach pharmacists how to bill on the medical side. Pharmacists will bill every day in the pharmacy when they submit a medication claim to the insurance company, but that's on the pharmacy benefit side, and it looks much different than billing on the medical benefit side. And so there needed to be a lot of education and training for catching pharmacists up to speed for that. So we kind of identified this problem. We had very few pharmacists doing tobacco cessation, but we also recognized that independently owned pharmacies, we're getting to the point where if only dispensing medications that's the only thing that they're doing, it's a struggle financially. And we could talk for hours about why that is. Anybody who's read the news and on the national scale and seen some of the working conditions at the corporate pharmacy level, those are driven by many factors, and our independent pharmacies are not immune to that. We're lucky that most of our independent pharmacies here in North Dakota, we're not seeing those walkouts because they don't have that dissatisfaction, and the working conditions are typically much better. But the financial component of dispensing, these pharmacies are struggling to kind of break even, so to speak. And so, the notion that pharmacists not only should provide clinical services and, in optimizing medications and chronic disease and obviously helping people quit tobacco, if we can find a way to bill for those, that's also a financial opportunity to bring more revenue and make that pharmacy more financially viable. So that's something that we identified as a big problem. And our hope is that pharmacists are going to then therefore be motivated to find more of these opportunities to bill for clinical services. And I'll tell you, I mean, again, it's like a small town. I know most of the pharmacists in our state, and every single one of them is in it for the right reason. They're in it because they want to improve population health in North Dakota. Um, and they actually get a little uncomfortable sometimes talking about, the money side of things and the revenue side of things. But as we all know, you have to have that in order to sustain a really well done clinical program that's providing those positive health outcomes. So we have to hit it from both sides. We need the financial component, but we also need the clinical component as well. So opportunities for partnership. I want to shift gears a little bit and just talk a little bit about why it would be a good thing for you guys to partner with pharmacists. And then I want to also talk about why it would be great for pharmacists to be able to partner with you guys. And I think you can start to already understand, just right off the cuff, we don't have many pharmacists that historically have been doing tobacco treatment. And so partnering with you guys as experts will really catch them up to speed as well. And it'll help us in the pharmacy world to get more of us comfortable and trained and used to doing this service. But a couple benefits to you guys for partnering with pharmacists, it's obviously a more efficient way for patients to access their medications. So having the patient be able to walk into the pharmacy. So like if you're counseling a patient to quit and you say, I want you to start on varenicline, and you walk through that and the patient agrees, and you say, okay, typically it might be, let's ask your physician if they're willing to prescribe that. And then we have to go through those hoops. And then the physician sends the prescription to the pharmacy, and then the patient has to go to the pharmacy to pick it up. You think about all those hoops they have to jump through to get to the end point of taking that medication. If we remove all of the middle stuff and we simply refer the patient to the pharmacy and ask them for varenicline, that's all it takes. So then the pharmacy in theory would be able to, go through their clinical consult with the patient, prescribe that medication, fill that medication at the same encounter, and get them started on it immediately. There's also something what we call primary non-adherence to medications, which means if I go to the doctor and the doctor prescribes me a medication to my pharmacy, primary non-adherence means I walk out of my doctor's visit, but I never go pick up that medication. And that unfortunately happens a lot. And I think we can all agree, we've all had a patient probably that was seemingly motivated to quit tobacco, and then they walk out, and we find when we follow up with them, they just never really followed through with anything that they planned to. And so I would consider that to be primary non-adherence as well. So it's a way by partnering with pharmacists directly, we can minimize that primary non-adherence issue. It's also another referral source. So obviously we're all used to referring to ND quits. Many of us refer to each other, whether it's from a health system to a public health unit or vice versa. We're all used to that, but this adds another source where, hey, if we know of a pharmacy locally that's doing this work, that's another referral source that we can refer our patient to, especially if they're already established at that pharmacy. And then just the idea that by having pharmacists involved, we're going to do what we do. We're trained in drug therapy monitoring and management and optimization. So when we're involved in that prescribing process, which we are anyways, but if we're the ones kind of heavily involved and we're the primary prescribers, we're going to make extra sure that we're monitoring for other drug-drug interactions. And the nice thing is, by having the pharmacy involved, is we know at the pharmacy all the medications a patient is taking. Whereas if they're at the clinic and they went to one clinic to get their Chantix prescribed, but they normally go to a different clinic, there might be a disconnect on the medication, so that the drug interaction piece might be missing to some extent. And so that involves a little bit more thorough evaluation of drug interactions. I also included a reference there, by the way. Anybody who's interested, that link will take you to the RX for Change website. They updated their drug tobacco interaction resource last year, so it's very up to date. It's a great resource if you're interested in learning more about that. And then again, optimizing tobacco cessation medication therapy, making sure that we are taking advantage of all the best practices. So using dual NRT patches plus a as needed option, using combinations of all different types of pharmacotherapies, combining varenicline with NRT or bupropion, combining bupropion with NRT, combining different NRTs, using high dose NRT. Those are all things that we're hoping to get our pharmacists up to speed on and comfortable doing. And then of course, again, the follow up and monitoring piece is always there. So on the flip side, for you guys to be a resource for the pharmacy in that collaboration, I think is equally as important for pharmacists to get up to speed, helping pharmacies overcome barriers. So for example, I'll talk a little bit about a project that we're working on where we're starting to see pharmacists collaborate with local public health units. And it's really an amazing relationship, because patients that come into the pharmacy, it's easy for us to prescribe, let's just say, nicotine patches. Well, the insurance should cover that, but there are situations where it's not always covered. And there are insurance plans that just don't cover nicotine patches unless it's coming from, say, a quitline program. And so to be able to partner with programs such as yours that may have that access to bridge NRT through the ND Quits grant or other resources, quit kits and things that you use, getting pharmacies access to utilize those, I think is kind of a win-win, because it satisfies what your goals are, but it also gives patients the access right away to those medications that they may not be able to afford. And then also, you guys can be a referral source for the pharmacies. If you haven't talked to your local pharmacies about this already, give them a call, because if they're doing this work or if they're interested in doing this, they may not have the capacity to start doing that counseling and prescribing right away. but at a minimum, they might be interested in knowing who they can refer tobacco users to, and knowing that they can refer to you guys, again, as a win-win in that scenario. And I mentioned the partner on funding. So like I said, we've had a few sites that have actually entered into various types of relationships with local public health units to be able to access Bridge NRT. And I'll talk a little bit about that here in a little bit in more detail, providing that NRT access to pharmacies. And then other scenarios. So you think about, some of the work that you guys are doing with immunizations and seeing patients in primary care. You might be involved in pre-op or pre-surgical care situations, transitions of care, patients going from discharge to some other care location. I mentioned rural areas, and obviously the big one is partnering with public health. But these are all scenarios where pharmacists can be involved, and are often heavily involved already without some of you maybe even knowing, and vice versa. So just to think about, if if you see your local community doing a flu shot clinic at a local high school or a local community center, it's quite possible that could be, those immunizations might be provided by a pharmacist or pharmacy team. And so is there an opportunity there to collaborate and maybe throw in a tobacco treatment component to that, or a way to identify tobacco users? Transitions of care, people going from the hospital to their homes, or a skilled nursing facility or what have you. How can we involve pharmacists in that with regard to tobacco treatment? I know many of us that have worked in the hospital are frustrated sometimes when we can get them started on NRT in the hospital, and then we discharge them and maybe try to refer them somewhere. But who knows whether they follow up. Well, if we refer them to their pharmacy where they can continue to pick up that NRT, again, that's a win-win on the transitions of care front. So those are some of the opportunities in specific scenarios to refer. And then finally, kind of going back to when a primary care provider has to be involved when it comes to pharmacists prescribing medications for tobacco treatment. I mentioned pregnancy, patients who are breastfeeding or planning to become pregnant. Those would all be scenarios where those patients can still be seen by the pharmacist. But in order for the pharmacist to prescribe those medications, they're going to need to consult with the primary care provider, or the provider, the OB provider per se. If the pharmacist determines that we need to use a sort of second line agent or non-FDA approved drug, like nortriptyline or clonidine, there's a few out there that have been used in practice, not real commonly, but they're not technically FDA approved for tobacco treatment. Those would be also situations where we would need to have more of a collaborative approach to prescribing. And then obviously anybody under the age of 18, the tobacco prescribing protocol in the state does not allow for us to prescribe for, kids and youth yet. That could change in the future depending on how things go. But for now, any pediatric or adolescent patients, we'd want to also involve the primary care provider. So I want to shift gears here for my last few slides and just give an example of what this is starting to look like. So I talked a little bit about, the fact that pharmacists just weren't really doing much tobacco treatment when all these laws and things fell into place. And then I mentioned we need to start looking at that. Well, one way that we're trying to do that is we're starting a pilot project in North Dakota. It's been going on now for a few months, where we have a few pilot site pharmacies engaged in trying to implement tobacco treatment programs. Um, on the research side of things, it gets a little heavy. We're trying to, use principles of what we call implementation science. And the reason I bring that up is, when this all first started, and I think about how busy some of our pharmacies are, I just thought, gosh, most of our pharmacists are probably going to feel like they just don't have time to commit to planning something like this. They don't have the staff maybe to commit to implementing like the ask, advise, refer process. It's going to be, that change is going to be hard. And so the question is, how do we overcome that? And that's where the implementation science thing looks at, well, let's just try it and see how it goes. And if it fails miserably, why is that? So it uncovers the why, which we call kind of contextual factors. What is holding pharmacies back from doing this? Before I move on and talk about a little bit more detail on this, I see I have a couple hands up, so I want to make sure I don't forget those. I see Chelsea, you've had your hand up for a while because it's up twice, maybe.
I think it's just on number 2 in line over Brady.
Oh,
but
you're number 2 in
but
line. Well,
I was gonna
I'll
say-
go. You get to go first because Brady already asked one question.
thank you. I appreciate all this, and yes, I think we all need to collaborate more with our pharmacies. But yes, I appreciate what you were just saying. Thinking about my own pharmacist, Tim Joyce out in Tioga, who services the Ray Tioga area, where 20 years ago he was probably providing for a population of 1,000 people. Now he's up to 500 or 5,000, 6,000 people. And every time I go in there, he looks like the mad scientist man. So just thinking about him and their pharmacy, I know that they're busy, and how are these pharmacies going to implement this into their day-to-day practices?
Yeah, great question, Chelsea. And that's a prime example of what I was just kind of referring to. Tim and his son Patrick out in Tioga, and Patrick's wife is working with him now. So they have the team of the 3 of them, and they are very, very busy. And they're not the only ones. You look across the state, a lot of our pharmacies are extremely busy. And so to ask them to dive into this is a big ask. And so I guess my answer to your question is we don't know how that's going to go, and that's again this project that I'm bringing up here is meant. The purpose of this project is to address that issue. And so what we've found so far is that there are some pharmacies who are very busy and they have been able to pull this off. Well, why is that? Why have they been so good at doing that? And what can we learn from them and bring over to a place like Tioga? And then we've seen some pharmacies who've really struggled. It kind of went like we thought it would. They're busy. They can't even find time to ask one patient about tobacco use. Well, why is that? What is it about that site that makes it so difficult? And again, what can we learn and try to pivot and find ways to help that site become successful so that we can then apply it to a place like Tioga? So I think the jury's out, and we don't know the magic formula on how to overcome that sort of busy pharmacy lifestyle, but we hope to get there at some point. Brady, you're up next.
Thank you. I just hopefully quick one. You did talk a little bit about the primary care needs to be involved for any prescribing to anybody under 18. Does that include prescribing for the patch or gum or lozenge like that? And if it doesn't include that, what are your thoughts on, pharmacists doing that on their own?
So that would include nicotine replacement therapy, both over the counter and prescription only. Any patient under 18. Interestingly, those products aren't FDA approved for youth under 18. They're only approved by the FDA for adults.
Right.
And so that's where, when this law was passed and we developed the protocol, for the time being, we kind of wanted to stick to some of the FDA approval things. Part of that was to make sure that all the other healthcare providers on the team were comfortable with what we were doing, and that essentially doesn't mean we can't prescribe patches for kids or youth. It just means we have to make sure that we're involving their primary care providers so that we have that extra set of eyes, a little bit extra attention, because we're kind of going off label when it comes to doing that. So it doesn't mean that it can't happen. It just means that we're going to involve the primary care team with that.
So for any cessation prescription or NRT, they do need to go through primary care.
That is correct.
Okay,
Yep.
good to know. Great, thank you very much.
Now, just to expand on that, again, that doesn't mean the pharmacist can't be the first point person involved. So, like, for example, if a teenager came to me and I was the first one, that maybe you referred the teenager to me, I would still counsel that teenager. I would still talk about drug treatment, but to actually get the medication prescribed at that point in time, then I would get the primary care team involved and say, hey, I have this teenager here that is your patient. We talked about starting on nicotine patches. I want to make sure I get your blessing on that. And would you be comfortable prescribing that at our pharmacy? And it's just, it could be a phone call. It could be as easy as that. So
And
it's not a huge barrier, but it is a barrier.
Do you need parental consent to go down that route?
That is a very good question. the law on that, I believe, is somewhat gray. There are situations where you don't need parental consent. There are situations where you do. I tend to defer that question to the primary care provider.
Okay, makes sense. Thank you.
Yes, sir. Chelsea, you got another question?
Yes. So if our pharmacies aren't doing any tobacco cessation or treatment currently, what is our ask? What is our first ask to have them implement first?
You know, I think based on what I've seen so far, and I'll talk a little bit more about what we have seen, but I think it's kind of like just reach out to them and say, hey, are you doing anything with tobacco cessation? And if they say no, it's maybe, are you interested in collaborating with us on any level? And if yes, then what, what could you do? And then I think it's just a matter of having a conversation about what you do. What could you do for their patients? Maybe it's just starting with them referring patients to you, and you just start small. That's something that doesn't really take much time from them. And if it's a matter of that they identify a tobacco user, and it's them placing a referral to make sure that patient follows up with you, that's a good start. That's starting to build that relationship. Whereas if they're like, yeah, we've been thinking about this, um, which I know Tioga has, because I've talked to Patrick a little bit about this too. So I think they'd be open to that conversation and just say, hey, what have you been thinking about? How could we help you, learn from what we do in the tobacco treatment realm? Um, Ask, advise, refer. What resources do you need? Things like that. So just kind of asking them what they are able to do and maybe what resources they need is a great place to start.
Thank you.
Absolutely. So a little bit more just to wrap up the last few slides. This project that we're doing right now, we have 10 pilot sites sort of entered into the project. As of right now, 6 of them are up and running, and they're all community pharmacies, but we kind of have a mix between rural areas and urban areas. And those sites are going through sort of a program that we designed to try to get them to implement this. And so, you know, i- this would be what I would say, kind of back to your question, Chelsea. What can we do to get pharmacies up to speed, or what's the first step? This is the steps that we took in this project. But obviously, these pharmacies signing up for this research project are kind of innately willing to do something a little bit more extreme, or they're willing to change a little bit about their practice. And so I think that's important to note. But what we've done with this group is we first provided them some baseline education. And basically what they did is they identified, 1 or 2, possibly more people at their pharmacy to be sort of a site champion, somebody to take ownership of the tobacco program, and made sure that they took this baseline education, which was kind of a refresher on tobacco treatment, ask, advise, refer, quit line, lots of different kind of education pieces. And those were online modules that they completed. Then we did kind of an in-person workshop where we brought all the pilot sites in person and went through a full day of trying to overhaul and redesign their workflow, taking them from what happens when a patient walks in the door today to the time that they leave. How do we change that to incorporate the ask, advise, refer, counseling, prescribing component in that workflow? And we spent a day doing that, and then kind of turned them loose and said, all right, go do it. And then we've been following up and doing sort of virtual peer learning meetings every month. And so sites can learn from each other, get tips and tricks on how things are going. And that's been really great. We also send some of our research team out to the sites to do regular site visits every couple months. Part of that is to collect data to see how things are going, but the other part is to do some coaching, which we call academic detailing, kind of on-site coaching. And then we provide them resources. So if they need, blank prescriptions pre-filled out with the tobacco cessation meds, we'll give them that. If they need, a drug interaction resource, we'll give them that. If they need a brochure to market their service, we're providing them with that. And so we're trying to support and take some of that a little bit off of their plate. And then ultimately what we're looking at from a research standpoint is obviously how good are they at doing the ask, advise, refer and treatment process. That's a piece of it, but that's the small piece. What we're really looking at is how good are they doing it? And if they're doing it really good, why is that? And if they're not doing it at all, why is that? And how can we as a team learn from the barriers that we identify, as well as the facilitators, the things that are helping them to do this really well? So we're seeing a few things. I'll kind of fly through this so we have some time for questions, but pharmacy technicians they are the heart and soul of every pharmacy. And we've found that when they are involved, there's a lot more buy-in, and the site is very successful with that. And if a technician is the site champion, they're going to really drive that program to be successful as well. And so not just having the pharmacist, but having the pharmacy technician engaged in that process is found to be very important so far. We've also found a lot of common barriers. So not being involved with tobacco treatment, as I said before, very few of us in the state were doing this work. Well, I think it comes with the territory that it's a little bit uncomfortable. You think about a rural pharmacy. Chelsea gave the example of a pharmacy that at one point had a population of about 1,000 patients. So they probably knew every single one of them by name, and they probably knew whether or not they used tobacco too. And so to then ask them, okay, now we want you to ask every patient every time they come in about tobacco use, there's just a little bit of awkwardness with that they need to kind of learn and overcome. And then also every encounter, that might be 3 days in a row for some people coming into the pharmacy to pick up prescriptions. And that can feel awkward. I just asked this guy yesterday if he smokes, and he said no. Why do I need to ask him again, right? And so overcoming some of those discomforts with that. And we talked a little bit about, time constraints are real. Staff buy-in is huge. Not every pharmacy staff member is highly motivated to do high-level clinical work. They might want to be more involved in the dispensing and counseling on medications, kind of that type of work. And so to get the entire pharmacy to buy in is very important, but it's a challenge sometimes. And then taking workflow that's been in place for years, sometimes many decades, and trying to overhaul and change that is extremely hard. Some of these pharmacies have been doing it their way for, since the early 1900s, and to change that, that's a big ask. And so we found that that's a major barrier. And so trying to overcome some of those things that we're seeing so far is, again, you leveraging the ongoing coaching, making sure that they're comfortable, that we train them on how to ask, not just being a robot about it, but what is a comfortable way to ask a person that was just in the day before about tobacco use again for the second day in a row? How could that look, and helping them train for that. Again, providing resources, reminding them that, hey, because the other thing is a lot of the pharmacies were thinking, gee, these people are also our customers. And if we're asking them about tobacco use, maybe we will offend them and drive them away. Well, we all know that 80% of tobacco users want to be asked to quit. And so making sure that the pharmacy teams are up to speed on some of those kind of factoids. Optimizing workflow, that's a work in progress. So finding the right time to ask about tobacco use is probably going to be different for every single pharmacy, depending on how they can standardize that workflow. But finding a way to do that system in 3 minutes or less in those busy places is of utmost importance as well. And I mentioned staff buy-in, very important. Again, a little bit more on workflow changes. We found that leveraging telehealth has been helpful. So recognizing that maybe that initial encounter is face-to-face, but their follow-up could be over the phone. And gosh, that's helped some sites really overcome no-show issues. Being able to call a patient when they have some downtime, it allows for that flexibility there. And so identifying some of those unique things with each specific site. And then just also recognizing that some sites are actually already partnering with you guys in public health, providing some bridge NRT. And that's been done through dispensing the bridge NRT from the public health unit. One site has been receiving reimbursement from the public health unit for dispensing bridge NRT. And we actually had one site enter in as a subcontractor of the ND Quits grant. And so a lot of different options and ways to be able to collaborate on the bridge NRT side there as well. And then this is kind of an overview, so again, just to recap. So starting off with trying to implement this intervention, kind of the top left circle there, that's where we're starting. But then through that process, we're trying to identify barriers. We're trying to identify things that are working well for sites. And those kind of lead us to uncovering all of these contextual factors. And a lot of those things, believe it or not, don't happen in the pharmacy. It might be, what is the population of their community? How are they seen in their community? Are they a staple of their community, or are they kind of hidden in the corner that not many people pay much attention to? Where are they located? How easy is it for patients to access the pharmacist in their building? There's a lot of factors that we're finding influence whether or not this is successful. And then we look at those as a research team. We use kind of an iterative process to continue to refine that intervention to keep trying to push forward and get places to do this. And so that's kind of how we're approaching just on a small scale. And the hope is that eventually we scale this up. But I think being able to have pharmacies hear about this and potentially even partner with some of you guys, I think you'll find that they're all open to it. And if they're not, it's probably because they just don't understand what those steps are. And so I think just having those conversations, as I said to Chelsea, is usually just the first step. Just see what they've tried, see what they're willing to try, and then kind of go from there. So that's it for me. I kind of included a few minutes here just for questions at the end, but we could also brainstorm on other ways, ideas that you guys have that you can partner with pharmacists as well.
There was one comment in the chat from Jennifer. It says she's excited their clients can go right to their pharmacy to get their varenicline, bupropion, etc., but the pharmacist has to still sign up for this program, correct?
Yeah, that's a good point. I think it would be good to, again, call the pharmacy and ask them, are you prescribing tobacco cessation medications? And they'll know. They'll know what you're talking about. They might say, yep, we're good to go. Or they might say, you know what, we're not there yet because we got to go through some of the hoops. Honestly, the only thing that they really have to do is complete that training module that's required by the protocol. It's a 1 or maybe 2 hour training module. Pretty easy. It can be done online, but that's really the only kind of step they have to take to then be able to prescribe. So it doesn't take much, but we're not quite sure if all pharmacies are there yet.
There was also a comment about pharmacists needing to be tobacco treatment specialist certified. That was also answered that it's just that module and training that needs to be completed.
Mhm.
So
Yeah, and actually that's a good point. That's not a requirement of prescribing, but it has become a common occurrence, I think, with pharmacists. They're finding that if they're going to start doing this work, they recognize that TTS training is so beneficial, helps with their comfort level, it makes them a better counselor. And so we're really encouraging pharmacists to take advantage of TTS training. And I think Neil and Kara have seen, attendance at TTS trainings by pharmacists has gone up quite a bit over the past couple of years, which is nice to see.
like Chelsea has her hand up again.
So talking about TTS training, and you said like pharmacy techs, could a pharmacy tech could be trained in TTS and kind of be the lead on the counseling and work with the pharmacist for prescribing and things, correct?
So I'll answer that in two parts. That's a great question, Chelsea, and that's not something I touched on here. But pharmacy technicians, to be a pharmacy technician, all you have to have is a high school diploma, and you have to go through a technician training program per North Dakota law to be a pharmacy technician. But it doesn't require a degree, a college degree. So that's the limitation on TTS training. I think as of now, TTS trainees have to have a degree of at least maybe an associate's degree or something like that. Some technicians do actually get their degree from Wahpeton Science for pharmacy technician work, but not all of them do get that degree. So I think as far as technicians doing TTS training, some may be eligible, but many are not. On the flip side, for technicians to be able to do some of this work, that is absolutely the case. In some other slides that I didn't include here, there's been a lot of research done on pharmacy technicians doing ask, advise, refer. And it's pretty clear that they're well trained. They get good experience through technician training to be able to do the ask, advise, refer process. The only thing that a technician can't do within their scope is clinical care. And so when it comes to prescribing and doing actually more thorough counseling on tobacco cessation, that's when the technician would then bring in the pharmacist. So I can envision some of these pharmacies developing a system where the technician takes ownership and does the ask, advise, refer process. And then when it comes to the more clinical component, they bring the pharmacist in for that kind of billable clinical service. Good questions. Other questions? I've included this picture in a couple presentations lately, and I stare at it and I stare at it and I still can't figure out what the heck it means. Well, thank you guys for all the great questions. And if you think of any offline, my email address is there. You probably all know how to get a hold of me one way or another. So don't ever hesitate to reach out.
Thank you so much, Brody. We really appreciate your expertise and sharing with us today. This will be recorded, or this was recorded, and will be available for those people who were not able to attend. So we'll live on in perpetuity with your great information. Thank you so much. Be on the lookout for our next edition after the holidays, after the new year. So we'll have something new for you. Thank you all.
Thanks again,
Thank
everybody.
you.